Since 2010, Mr. Mike Glenn has been the Chief Executive Officer at Jefferson Healthcare, which is located in Port Townsend, Washington. Jefferson County Hospital is a 25-bed critical access hospital that provides a comprehensive array of services to serve about 29,000 residents and operates 8 primary care clinics as well as a home health and hospice agency. Mr. Glenn has nearly 20 years of executive leadership experience. Mr. Glenn holds several board positions and has affiliations with several state and national health organizations. He is a native Washingtonian with Masters of Health Administration from Xavier University in Cincinnati, Ohio. Hillary Whittington joined Jefferson Healthcare as the Chief Financial Officer in 2011. She previously worked in public accounting, where she specialized in audit and reimbursement services for critical access hospitals. Hillary obtained a bachelor's degree in business administration and accounting from Gonzaga University in Spokane, Washington. Dr. Joe Mattern is the Chief Medical Officer at Jefferson Health and is the Medical Director for Jefferson Hospice. He graduated from the Drexel College of Medicine in 2000 and then completed his residency in family medicine at the University of Wisconsin, which included service as chief resident. Dr. Mattern is board certified in family medicine and has a well-established clinical practice for over 10 years that has included both inpatient and outpatient services. Dr. Mattern has lived in Jefferson County since 2003 and has served many different leadership roles at Jefferson, including Medical Director of Ambulatory Care and Chief of Obstetrics. Dr. Mattern is also a former participant in the Washington State DOH Medical Home Pilot. Terry Hill, Executive Director of Rural Health Innovations, will facilitate today's discussion. Now I'll turn it over to Terry and our team from Jefferson Healthcare.
Thank you very much, Kim, and welcome everybody to the Performance Management Group call. This has been an educational vehicle that we've been using for a number of years in this program, starting with our Rural Hospital Performance Improvement Project in the Mississippi Delta region, which we basically implemented for about 13 years. So we have spent a lot of time working in and with rural hospitals across the United States. Just in the past year, we expanded the program, which had been pretty much confined to the Mississippi Delta region nationally. And also, we took on a somewhat different role besides the performance improvement aspects of this program, which was the basic focus in the early iteration. The new small rural hospital transition program is looking not just on performance improvement, but also on how rural hospitals can make the transition to value and performance and accountable care organizations, medical homes, etc. So the new models of care that have been developed and are being implemented across the country. For those of you that aren't following this very closely, we are anticipating a dramatic increase in the number of rural hospitals participating in accountable care organizations. As of January 1st, a significant number, well over 150 new rural hospitals are going to be joining the relative handful of rural hospitals that have been participating up to this date. And so we're going to see a significant number of Medicare-covered lives now being located in rural areas, and we're going to see a significant increase in the number of rural hospitals participating in accountable care organizations. We're really fortunate to have a hospital that has been preparing for accountable care organizations for quite some time. And the three leaders that will be profiled today that we're going to have as a part of our panel kind of represent three key elements of that leadership team. Mike Glenn, as we know, is the CEO of the organization, so he kind of has the ultimate responsibility, kind of leading the transition and value. But Hillary Whittington, the CFO, really represents an incredibly important perspective, and that is how do we make this transition? How do we cross the, we've used this metaphor of shaky bridge so that we can succeed in the value-based system, but not bankrupt ourselves along the way. And so the financial strategies we believe are going to be very important. And the final component here that's important is the medical leadership part of it as well. And the National Rural Health Resource Center has a primary responsibility of basically working with rural hospitals, identifying what is happening with rural hospitals in this transition to value, et cetera. And through funding from the Federal Office of Rural Health Policy, we work in partnership with the University of Iowa, the RUPRI, Rural Health Value Programs, et cetera, to kind of profile what is happening and trying to kind of translate the lessons learned to other rural hospitals as well. So I'm excited about this program for a variety of reasons. One is that we're going to look at kind of a real-life example of a hospital, the kind of decisions it's making, the preparation it's making as it's moving into an accountable care organization at the beginning of this coming year. A second major focus is going to be on the medical staff and how we engage and basically partner with medical staff, because primary care physicians, as probably many of you know, are kind of at the core of this new value-based model. And it's incredibly important that hospitals and medical staff work closely together. And kind of in that regard, we're trying to identify what are the crucial variables in terms of getting physicians actively involved, forming those partnerships. Kind of how do we get the physicians and the hospitals working closely together? Again, as we look at the value of primary care physicians in the system, people like Eric Schell, who's a consultant for Stroudwater, and other consultants we talk about immense financial value of primary care physicians. And the other very strong recommendation is that without that partnership, hospitals are really going to struggle. So with that said, we're going to start out, I'm going to ask Mike Glenn, the CEO, to talk a little bit about your hospital. And kind of in that regard, how did you determine that the accountable care organizations were the right way to go? And how did you prepare the hospital moving forward? Mike, I'll turn it over to you.
Great. Well, thank you. But with Jefferson Healthcare, I think it's a fairly typical small rural healthcare system. We are a public hospital district means we are governed by a 5-person publicly elected board and have 2 open public board meetings each month. So I think it's fair to say that there's a high degree of community interest in the work that we do, whether it's recruiting a new orthopedic surgeon or implementing a clinic redesign in one of our primary care clinics. But I think over the last several years, our focus has been on the traditional list of things that hospitals need to pay attention to. We went through an electronic medical record implementation a couple of years ago, and that was a huge and important project. We felt that we needed to better position ourselves in the clinics for changing reimbursement models, so we implemented a clinic care redesign that we'll likely talk more about later in the hour, that focused on improving the patient care experience as well as opening up access. So that was fairly traditional work, and we are about halfway through a new building addition as well. But in Washington State, there's a fairly ambitious program at the state level to truly be a recognized national leader in care and payment reform and redesign. So while we were watching that unfold at the state level, a couple of early adopter hospitals also began to position their organizations to play in the rural ACO world. So we actually looked at participating in a rural ACO last year and got all the way up to the starting gate before we concluded that we hadn't gone far enough in our clinic redesign work to take this on. And secondly, we were about a year away from this new building distraction to where we thought we could be successful. So that actually turned out to be a good decision for a couple of reasons. One, we were able to just sort of watch these 2 early adopter hospitals participate in that and pick their brain on what worked and what didn't work. And 2, it allowed us to really bring our clinics to the point where there was enough engagement and interest and competence in this changing world of patient management that we thought we could be successful. So we really feel that now is the time to begin to dip our toes in what a rural ACO program could look like, with some degree of upside, but really negligible downside.
Mike, were you able to access the new AIM funding that's available, the loans that were available?
Yes, that our ACO was able to receive some of that funding.
And how was that going to be helpful to you?
Well, it's going to help with some of the startup administrative costs. as we stand up this new program.
Terrific. Did you have any concerns on the part of your board of directors as you moved forward? I know some hospitals have told me that's been a significant obstacle. Give me a little idea what your experience was with your board.
Well, we are blessed to have a very supportive, engaged, and progressive board. So they have been going to educational sessions for the last couple of years, and they understand where healthcare is going, and understand this dilemma of having one foot on the dock and one foot on the boat. And so it actually was helpful to take a good long look at this a year ago, because we moved the board along and had them understand the upside as well as the downside, and we really sold it to them as a way for us to begin to learn about managing a different way in managing our patient population. And our eyes were wide open as to what that may look like, and I think they were comfortable. When we decided to wait a year, they felt that was a prudent decision, but I also think that they understood that it was quite likely that we would be coming back to them in 6 to 12 months and say we're ready now. So because of all of that, the board was and continues to be supportive, recognizing that this change is likely inevitable, and it's probably best to be a little bit out in front as opposed to a little behind.
Mm-hmm. Like, as you look at moving into this new accountable care organization, do you have any primary concerns? You've obviously done a good bit of preparation. You feel the timing is right. Would there be concerns on your part of anything in particular?
Well, the delay from when you launch and are responsible for the management of the patients that are attributed to the ACO to when you start getting utilization data that you can act on. That a lesson we learned from the early adopters who jumped on board a year ago, that delay was as long as 6 to 9 months from when the data started to come in and was actionable. So you begin to implement the different care management programs, and thinking that this is the right work, but we really won't have data on our patient population to review for at least 6 months, and that's a little concerning to us.
Sure. So in essence, the claims data in particular, from what I've been told, becomes really essential to effectively managing the patients. And again, for those of you that might be in the call, let me just briefly explain. An accountable care organization is a group of healthcare providers that take responsibility for the comprehensive cost and care of a group of Medicare patients. We also see this occurring, similar sorts of models in the Medicaid system, and increasingly other third-party payers, the Blue Cross Blue Shield of the world, United Healthcare, et cetera, are all moving, it appears, in the trending towards accountable care organizations as well. So any other concerns? Are there any financial concerns? I'm going to ask Hillary in a minute about that, but do you feel you're pretty much adequately protected then given the resources that you have and kind of leaving the dock or crossing the shaky bridge or however we want to put it?
Well, at this point, yes, it's a fairly risk-averse way to begin to orient toward ACO, an NACO, and I think we're in a pretty good place to begin this.
Are you pretty much convinced that the market is definitely moving in this direction, and that the future kind of is going to be some iteration of this value-based type of payment system?
Yes, absolutely. Likely, a different acronym, but there's very little question in our mind that a value-based, population-based approach to taking care of your community is coming.
Yeah. I would agree with you. All the signs are pointing very strongly in that direction. Let me ask Hillary a question now from a financial standpoint. I've had a lot of questions from CFOs for rural hospitals across the country about kind of the financial aspects of moving into this new payment system. So Hillary, would you provide some perspectives in terms of what you see as the opportunities and the concerns you'd have, et cetera? What's it like from a CFO's perspective to move into this new payment model?
Absolutely. Good afternoon. I think the biggest factors that we considered as we were heading into this is the upside and the downside risk of pursuing a new model. So there's certainly a downside risk when it comes to exposure on the expense side, though some of that we're a bit insulated as a critical access hospital because the costs associated with going down this path are subject to our cost report and cost-based reimbursement. So that was one concern, is just how are we going to pay for care coordinators and the admin fees for it. The AIM funding will certainly help, though when we're starting any new program, we don't like to consider a grant as a reason to do or not do a program, knowing that if it works long-term, we'll be tied to the program and won't have the grant funding. So we thought through that side, but really as a critical access hospital, the best thing we could do as we headed into this was to be really transparent with our leaders and our board that we knew something was coming. So Mike started those conversations back in 2010, and we've been pretty consistent with how often we talk about something's coming. And not necessarily in the dinosaur Jurassic Park way, but almost, and setting the tone that we need to be ready as a very strong, independent hospital for whatever's around the corner so that we can be flexible going forward. And that's really the dialogue that we've been having with our leaders for the last 5 years is, we weren't sure if it was going to be medical home model or, capitation or what it was going to be, but something where we needed to be flexible was coming down the pike. And there's always a crossover period with any program, and we're joining this model of ACO, we aren't exposed to a lot of risk, but there is a period where we'll be virtually running our old model while adding in care coordinators, and cost-based reimbursement isn't changing, but there's this new consideration. Probably the biggest risk that we've talked through is, what if we do a great job at this? If we do an excellent job at managing care, we actually reduce volumes across our organization, and that's a threat to us. There are caps of costs, and there are considerations when it comes to volumes we need to maintain a healthy bottom line. And if we're reducing volumes, we know that will ultimately reduce our margin and start eating into reserves that we've spent a lot of time and energy building up. The contrast of that is that we've started to brainstorm how we can kind of offset that threat with using information to learn about our utilization patterns so that we can ensure that we're keeping as much within our system, or at least keeping our patients out of those really expensive environments to offset some of those volume reductions. If we're cutting down on inpatient utilization, that's okay as a trend, as long as we're considering how we can keep referrals in our system for other services across our house. So that's been the main focus, is coming up with strategies to affect referral patterns so that any reduction in utilization caused by this and caused by great care coordination doesn't harm us financially more than the expenses of the care coordinators and other folks needed to support the system.
Hillary, another strategy that I've heard expressed, because it's kind of complementary what you talked about, is that if we're going to lose inpatient volume, we have to do everything we can to increase our outpatient volume in that regard. And very often there are opportunities to keep people locally. If we've got a lot of rural hospitals have a significant amount of their market that leaves, and kind of capturing some sort of a substantial percentage of that becomes another way to offset that inpatient volume lost. But you've obviously got this through, and you folks seem really well positioned. The other thing I would say is that I think Mike mentioned Washington is really on the head of the game for a variety of reasons. It's really focused in on creating collaboration between the hospital and other providers in rural communities. So that seems to be very progressive as well. And as mentioned, there are a number of different demonstration projects, kind of value-based models taking place in the state. So that's been very positive, I'd imagine, as well. I think anything else, Hillary, in terms of what about the relationship? We're going to now turn to more of the medical staff itself. What sort of strategies are you thinking of, or what perspective do you have on engaging rural physicians?
I think the biggest thing that we've tried to do is inform our medical staff about what we're thinking about. Looking back, I think we would have started this conversation a lot earlier than we did. It was kind of a lesson learned. But if we can capture their interest at this point, we should have a pretty smooth entrance into this program. The first thing that we've done is have discussions at the medical staff meetings about what is an ACO and how does that work. We started that a little over a year and a half ago, when we were first toying with the idea of starting this organization. And as we've gotten closer to the state, we've had roundtables with physicians and medical staff about just explaining what it is, how it impacts them. We got to a place where some of our physician leaders became pretty educated about what ACOs are, and there are a lot of both horror stories and stories of success across the United States about ACOs, and it's important that we can translate what providers are learning in CME and other opportunities, and cater the message that they're hearing to set reasonable expectations for a 25-bed critical access hospital in Fort Townsend. That's been an interesting lesson, is just figuring out how you can first address the local market and how an ACO can play into our environment, but also make reasonable expectations or estimations of what any potential shared savings would be for the physicians. And that's really where they're hearing mixed messages from different educational opportunities, and it's important that we can set what would be reasonable in our environment. Heading in, we were using estimates, and that's really all you can offer. But that's a spot where getting physicians engaged, it's a really important factor that we can share expectations with them, and we didn't necessarily have them going in.
I'm going to turn now, thank you, to Dr. Mattern. And Joe, we've had some preliminary conversations about both the importance of getting physicians involved early on, but also how to engage physicians in value-based models, medical homes, accountable care organizations, et cetera. So give me a little bit of perspective, if you will, about kind of what is happening in your medical practice. I think you have something like 8 primary care practices or 8 physician practices associated with the hospital. And as Chief Medical Officer, kind of what are you dealing with in this regard? What's your perspective on this from a physician perspective?
Sure. Well, thanks again for having us on today. And this topic is a really difficult one. And physician, if we just step back away from just talking about engagement to a value-based model and just say physician or provider engagement alone, it's a really difficult thing. And it is really, really hard work, and it's something that we've decided to make a priority for our organization the last couple of years and moving forward, because as we're going to talk about this aligning and walking forward kind of together, you got your administrators, you got your clinicians, and really the ACO model has to be clinician driven if it's going to be successful. And you really need to see the alignment between those two parties. And so the challenges with providers, most providers are trying to keep their heads above water these days. The burnout rate is increasing amongst providers, and you study from Mayo Clinic up to 45%. So that means that at any one time you're talking about half of your medical staff, or almost half of your medical staff, is physically, emotionally exhausted or does not find purpose in the work that they do, and that's really sobering to think about. And so here you are, you're trying to kind of reach out to these people. And in rural institutions, their capacity is often less than maybe bigger organizations where people have to, or don't have to wear as many hats. It's not uncommon in rural institutions that you have your chief of staff is also your liaison physician for your home health agency, but also does some medical director work and takes a shift in the ED. The capacity then to engage a provider on a new project or a particularly a transformative type of project is very difficult because a lot of times they don't have the space to even wrap their head around it. And then also, when you're looking for your physician leaders or your provider leaders, you've got a shallower pool because you just don't have as big a medical staff. You know, if you've got a small 25-bed hospital and you've got really kind of 50 active medical staff members, that's different than a large organization who might have a medical staff of 500 people to pull from. So that's where you're starting. So that's, I think really speaks to the difficulty of the situation. But you can approach it, and I think the first thing you got to do is you got to assess your current state, and you got to ask yourself, what is your existing relationship with your providers, and that can be, have you assessed your provider group to see what is their level of satisfaction, what is their level of engagement. There's tools that you can find in to survey that and get some sense. You can certainly also do the qualitative approach of just walking around and talking to people and seeing what's the feel, and engage folks that way. The other thing too is what is the relationship of your organization with the providers? Are you aligned with independent provider groups, or are you the employer? In our situation, we're primarily the employer of our providers. About 98% of our medical staff is employed by the organization, and that has its benefits, and it also has its challenges, because I think we were talking this morning in the group saying that I think sometimes it's the employed model creates a sense of shelter for the providers. I think the administrators want to provide shelter from the difficulties of medical practice, whether it's the business side or the operations side, and try and a lot of times you see provider practices going to selling other practices or joining employed models because they're looking for a sense of shelter. But I think that creates a problem, and I think one of the things you have to do is reset a little bit of the culture, because I think instead of the idea of the shelter in the storm, I think the new analogy that I think Minister using is kind of two mountaineers roped together trying to climb the mountain, going step for step with one another, and if one person falls, the other one's coming off too, or it's going to hold the other one up, depending on what that relationship is. So we're really kind of tied together, but I don't think sometimes that we don't step back and kind of look at sort of the culture of our relationships with the providers, between the providers and administration, because they speak very different languages. And if you acknowledge that and start to realize and start paying attention to what the provider speak is and teach providers a little bit of what the administrators speak. That's what the chief medical officer does. I joke around that administrators are from Mars and clinicians are from Venus, which puts the chief medical officer on Earth between both worlds. So you have to be able to kind of translate, and you have to be able to have a communication where both parties kind of understand each other. The other thing, too, I think for rural that actually is a benefit, moving more specifically to the ACO model, is being primary care centric. I think more likely in rural health systems, you're going to see organizations that generally are supported and are critical to primary care, and primary care has been critical to their success. Some bigger organizations, more urban, that's a real change in culture for those organizations. But in rural, I think it fits nicely. But I think it's still important to understand whether you're primary care centric or not. So I think those are kind of the starting points of the things to think about as you're kind of beginning to engage, and you really have to do this assessment and then look at where, where's your staff at? What kind of work do you need to do? What kind of foundational work do you need to do in leadership, in the health of your provider group? So one of the things, or some of the things that we're doing right now, is we actually have put physician provider burnout on our strategic plan, and we don't have all the answers to it, but we've begun with some educational events. We're going to try and promote some increasing peer support, some mindfulness programming, just some idea of encouraging providers to take care of themselves. And then the other thing we're looking at, or the other things we've started, is redesign of practices to try and create work environments that are more sustainable and feel more rewarding to the practitioners. I'll stop there.
I think, yeah, that is all great stuff, by the way. And I think you hit on something that I really want to underline, and that is assessing the physician's readiness for change, their satisfaction, et cetera, because primary care physicians are in short supply already, and we're not going to expand the numbers in the foreseeable future simply because we have no more primary care residency openings out there. And meanwhile, the demand for primary care physicians is really expanding because, as you mentioned, they're kind of at the heart of the medical home model and actually the ACO itself. So really finding out where the medical staff stands and the other thing I tell hospital leaders is, if you're going to ask them, don't ignore their input, because that tends to really irritate physicians in general. So, I mean, it is trying to assess, what are their issues, what are their motivating factors here, and I really like the example of the two mountain climbers kind of roped together. Talk a little bit more, Joe, about the difference in perspective, because I know exactly what you're saying in that regard, and it's too often overlooked. The physician perspective versus the hospital leader perspective. Why do you say one's from Mars and one's from Venus?
Well, clinicians think in terms of a professional relationship, which they, typically you get to think about sort of who they are and why they went into medicine. And they typically went into medicine because they wanted to do important work, they wanted to do meaningful work, They genuinely want to help people. They want to make them well. And the crux of the relationship is a professional relationship, and they think in terms of patients, not kind of clients or consumers. They think in terms of quality and safety, and particularly because we now have generation of grads out of medical school and residency who never owned a practice or kind of really been in the world of having to operate a practice. They're removed from the other side of medicine, which is this relationship, which is a bit of it has definitely evolved to a consumer experience. And we were at a talk about a year ago where a point was made that the professional relationship is what exists between a provider and their patient. When a patient comes in to see me, I'm there to assess the problem, and I'm there to give my professional opinion about what I think is going on and what is the best course of action. It is not necessarily what the patient wants to hear or wants to be told. And so there's a conflict when you have discussion around the experience in medicine as far as patient satisfaction surveys or kind of availability or accessibility of telephone visits or e-visits or all these different things which really are threatening to the provider who feels like, well, I've got this relationship. It's not there to simply just do whatever the patient wants. I can get a higher patient satisfaction score, be available all the time for that. So they don't kind of recognize the fact that professional relationship is, while it's important, the patients do find all that other stuff, what your clinic looks like, how accessible you are, whether you can be reached by telephone or electronically, and what the cost of your visit is. That actually does matter to them, but in the clinician mindset, they're just thinking about that moment, patient in front of them, the safety of that patient, coming up with the right diagnosis, coming up with the right treatment plan, and developing a relationship. So you actually need both things to have a successful practice. And so that's the first thing, is kind of acknowledging and sort of recognizing with clinicians that there's a little bit of this conflict with, particularly around the economics of practice. So the idea of, we need to see more patients in the clinic. One of the things that when I talk about sort of how many patients we need to see in the clinic, I don't talk about it from the financial bottom line. I know what that financial bottom line is. What I talk about it is more from the point, Terry, you alluded to, which is there's only so many primary care clinicians that are available, and while it might be ideal to see a smaller number of patients per day, that will not meet the need of the community. And so understanding, because the health of the community is something that my clinicians can get behind. Access to the patient not having an appointment with a primary care clinician, not being able to get into an appointment, that they can respond to, and the need to have access. But if you take the administrative, which sometimes the chief financial officer is going to feel more comfortable maybe talking in terms of economic terms, right? They feel comfortable with spreadsheets and cost per visit, return on investment, but you're speaking a different language, and your clinicians are not necessarily going to respond. So that's just, I think, one example, and there's many more out there. But recognizing that the way that you kind of talk about care is important, and engaging clinicians. So Does that help?
It does, and I think you articulated very well that in essence the physician's focus is really on this patient-centered care, and in essence that's what these new models are bringing. So it strikes me that's something that's in it for the physician and for the patient as well. But in order to manage a group of patients or a population in general, like an accountable care organization, you're going to need the skill set of the hospital or the folks to manage the finances, et cetera. And you've got to take a collective look at the population. And so the combination of both of those perspectives are essential. They are, to me, the hospital doesn't make it on an ACO unless the physicians are engaged. And conversely, it's going to be difficult for physicians alone to be able to drive the management of larger populations in that regard. So that's totally agree with what you have to say. Let's take a look at how things are going to change. So in essence, if we are now going to be responsible for the comprehensive health care of a group of, let's say, 5,000 to 10,000 Medicare recipients. Remember, these aren't all patients; they're recipients in that regard. What are we going to have to do differently? Let's take a look at the clinical processes in general, and I'd invite Hillary and Mike to jump in on this as well. How are the clinical processes going to change? What's the care coordination strategy here?
Well, I think to begin, what we've told our primary care clinicians is just kind of keep doing your thing right now. We mentioned we did a clinical redesign which has improved access within the clinics. It's cut down on third next available appointments and opened up slots. So that's the main focus I want them to pay attention to, because that all is still fairly fresh and raw, and we are still trying to improve the patient flow through our clinics, and that's really critical, because I think no matter what kind of model you have, you're going to need to be accessible to your patients to be successful in ACO. That model may change with the payment, so that one day it may not mean that I need to have 18 to 22 patients come through my clinic doors to see me in a day, but it probably, if it changes, it might mean maybe only 12 patients came through my doors, but I probably spoke with 6 on the telephone, and I probably Skyped or had electronic interactions with 4 to 6. And the tough thing is that we don't really know where this model's going to end up, and that's one of the reasons why the clinicians also need to get engaged, because the model, I don't think there's any two ACOs that look exactly alike, and so how we do this work is going to need alignment. But in the initial stages, we want them to do their things, and then the one win for us here is that in the beginning we're essentially adding resources to help them with their work. So the care coordinator hire, which we're going to use a nurse model for our care coordinators, and we're hiring 2, maybe as many as 3, once we know our final attribution numbers for our organization. And those nurses will be assigned a panel of Medicare patients, recipients, and we will then look at those populations and try to identify the highest risk patients, heaviest utilizers, and see where we can put additional efforts as far as care coordination and directing additional resources to those patients. One of the things we've done in the last year, once again in preparation for this work, is we've added behavioral health into our primary care practices. So we've begun to augment the behavioral health work, which is a huge part of primary care, any primary care practice. It's as far as utilization and providing higher value care, you need to get a handle on this. So we're using licensed clinical social workers in our rural health clinics, as well as we've also collaborated with a local mental health agency to share a psychiatrist who provides consultant duties for us through the week. So that's a new add, and so once again, from the clinician standpoint, what we're trying to do is add these additional resources and tell folks. So what you're gonna recognize is that people are gonna begin coming to you to say, how can I help with these patients, and have an additional resource to turn to, which is an appealing start compared to some of other transformative projects. Take like an electronic health record, where you pretty much blow up a provider's workflow and have to rebuild it back. So this is once again the sort of low risk. We feel a little bit better about this kind of transformative change project.
And I think, kind of not going first, as you mentioned earlier, kind of into the accountable care organizations, you do have the benefit of the track record of the number of rural hospitals that have been doing ACOs now for several years. And I think you hit on several of the issues that we're hearing as well. One of it is that behavioral health is emerging as a major issue for accountable care organizations for a variety of different reasons, and it hits both at quality issues, but it really hits at cost issues as well. So that the comorbidity and when you've got depression and you start looking into high cost users, there's very often a mental health factor that is there as well. So kind of knowing that as you're moving into this ACO, you can be prepared for that. And what I hear you say is that you've already lined up, a mechanism to deal with that. Another thing I hear over and over again is the emergency room and the inappropriate use of the emergency room, and the development of emergency room diversion programs to try to find a way to get people into the clinics or into the, rather than into the emergency room after hours. So those become certain avenues as well. Talk a little bit about more the teamwork approach. Who do you see as part of your care coordination team?
Well, we're actually creating a little bit of a department around the ACO, and it's basically our care transformation department, and we definitely see our care coordinators playing an important role. Mental health, as I mentioned, diabetes education, wrapping that in more to this group as a support. And we're even talking about our bereavement support through our palliative care initiatives, kind of wrapping that in. And the idea is that that's going to augment the core model in the primary care clinics. And we made use of a group called the Coleman Group last year, who's done a lot of clinical redesign heavily in primary care for the last 10 years, and we came to them through a recommendation from a relative of one of our providers. And the care model, as we're evolving it, involves the provider and typically provider and medical assistant, part of a care pod, typically with one or two other providers and medical assistants. The medical assistants we actually refer to as the Sherpas to help the provider move through the day. So I guess they're roped into the provider as well. And then we also make heavier use of RN support in our clinics. That actually has been held over a little bit. We were the pendulum has kind of swung back a bit. A lot of you saw nursing roles leave primary care clinics. I think about 10 years ago, you seem to see less and less of that, and now I think there's a little bit more of a swing back. And our tactical nurses are designed to do nurse visits as well as triage and hopefully help kind of move the team through their day. So that's the core team. So basically the kind of your care pod within your primary care group, and then your support, additional support that we're adding in. I should also make note, though, that we are at a distinct advantage because we have some things that other rural health systems don't have, which is we have an enterprise-wide electronic health record. We're on Epic. We're in the Puget Sound area, and a lot of hospitals in Puget Sound are on Epic, and we actually are able to track our patient visits across our organization as well as kind of better awareness even at other organizations. If we're about 2 hours from Seattle, and our patients often times are transferred there if we can't take care of them here. So we can actually track their hospitalizations through our EHR. So we have an incredible advantage, and I consider that one of the tools in taking care of the patient. We also have mentioned before, a home health and hospice agency that is also part of the support team, as well as kind of a cadre of specialists. So kind of I refer to sort of creating the medical home and your medical neighborhood, and we've got a pretty healthy medical neighborhood.
Yeah, and I think that what's exciting about this is that it is there truly is alignment of interest and goals at the provider level, at the chief medical officer level, and at the CFO level, and at the community level, as we stitch together this team and implement more of an integrated and formal approach to providing the best care that every primary care provider wants to provide. Colonoscopies when a patient turns 50, mammographies when necessary, diabetes managed and under control, and not by accident but by design. So we are pretty excited about formalizing that across the primary care base, knowing that it has to be consistent with this evolution from fee-for-service medicine or payment to value-based payment to maybe even population-based reimbursement in rural communities. That